sir to chair this session along with Dr. N. Srinivas, who's consultant critical care at Care Hospital.
Okay, first of all, thank you very much, Maharajji, for the kind invitation. There he is. I'm already worried because Arindam started off by saying that I am an eloquent speaker, and then he went on to say common sense is most important. So I don't know whether I'm an eloquent speaker or I lack common sense. I need to sort of work on that now. Anyways, the topic which I have been given today is the GUTS protocol. Okay. So the use of this GUTS protocol ultrasound, point of care ultrasound in intensive care unit. It is something which I think many of you might be practicing, but more often than not, the radiologists practice it in our intensive care units more often. We as intensive care specialists, those of you who have interest in it, would put up some effort to sort of get some sort of an expertise. And I can tell you, I've been doing ultrasound, started off with cardiac ultrasound way back in 2001. And even now I find this difficult to do an entire study all by myself because that's not something which is our core competence. Okay, so what does GUTS stand for? It is a gastrointestinal and a urinary tract ultrasound. Okay, so that's what GUTS protocol stands for. And the reason why it came into prominence in ICU practices that we believe that gut forms an important part of dysfunction in a critical ill patient. So somebody who is critically ill, we always are worried whether the patient is absorbing fluids or not. Do they have a non-specific reason for pseudo obstruction? Are they emptying their bowels or not? So all of these questions come to our mind, and we are aware from our previous studies as well as data coming out that in fact gastric tonometry was one of the best markers for hemodynamic assessment. Unfortunately, it did not get the same amount of prominence what some of the other markers have got. So gastric tonometry sort of got left behind a little bit and we moved ahead. I think we are going back to sort of see how ultrasound will help us define or identify GI disturbances in the ICU. Obviously, it's a cheap, it's a relatively inexpensive because the machine is there. You don't really spend anything while using the machine. The hospital invests on the machine and then you have the machine to use it. Provided you have your local PCT acts in place, your accreditations in place, go ahead and use it. If it is not, I would recommend that use it only in males. Don't even go near a female. I'm very clear about it. I always tell my team that it's got to be very clear what we are using and what we are not using. And obviously, it's non-invasive. So there are a number of definitions of GI disturbances in ICU, and this European definition seems to be the most simplistic. It talks about grade 1, which is self-limiting. You don't need to really do much. You may just put in a nasogastric tube, empty the stomach. From next day onward, the GI tract starts to move. You don't really have to worry about it. It was sort of sluggish, it picks up pace. Then there may be some which would require a quick intervention. For a quick intervention, you might want to give a prokinetic drug, for example, and your intervention might be good. Then there would be grade 3, which despite your efforts, it's not restoring back the function. In fact, the lactate is rising maybe. You're worried that is there an intestinal ischemia? Is the gut emptying properly or not? And then the grade 4, which we all worry about, severe organ dysfunction, the GI dysfunction, like an abdominal compartment syndrome, where you need to do something dramatic to actually try and relieve this problem. Otherwise, this problem is going to become a syndrome in itself and be the main part of the patient may critically ill. These are various things which you may potentially diagnose. I can tell you I can't diagnose half of them myself. Okay, so it's very difficult. In most radiologists, if you and we've got a radiologist chairing the session as well, unless they are expert who do day in and day out, most of them would again put at the end of their report that a CT correlation might be required for some of these conditions, not all of these conditions, but some of these conditions. For example, if you want to really comment on bowel ischemia, you would want to do a CT correlation before you subject a patient to a surgery, for example. So these are some of the things which we need to understand. There are limitations of it. And when you study this, I have been doing this on and off for the last 4 or 5 years. It's not a very methodical protocol that I follow, but now that I started sort of reading for this talk, around a year ago in Mumbai, we decided that why don't we have a sort of a protocol in our unit. I can tell you it's very difficult. The protocol doesn't get followed uniformly, unfortunately. That's the reality of it. But the endpoints are that you look at the diameter of the gastrointestinal tract, stomach, as well as the intestine, the small and the large. You look at the mucosal thickening. You watch for peristalsis, whether the patient has a peristalsis or not. And normal peristalsis is difficult to get at times. It is the hyperperistalsis which is easy to get. Blood flow, I struggle. I struggle to identify the vessels correctly many times, and so do my residents struggle as well. Bladder and prostate is easy, it's not usually difficult. We are able to find out quite easily. And some of the other things we are able to do, like ascitic tapping, looking at the kidney, looking at fluid in the Morrison's pouch and stuff. Those are easy stuff to do. But these main few or 4 or 5 things is what the endpoints are. It's not a workshop, I'm not going to talk about how the probe is placed and stuff, but the gastric ultrasound starts up with your GI ultrasound. So your main best protocol starts with the gastric ultrasound. You usually use a curvilinear probe, which is between 2 to 7 hertz, 2 to 5 hertz. Some of the machines are 2 to 5 hertz. You go a left subcostal and epigastric view. You try to look at a cross-sectional area and look at a gastric antrum and see for dilatation or collapse of the gastric antrum. That's what we want to sort of see. Typically, we know that when you look at structure in the intestinal tract, you see this picture on the left there. I don't know after marker is not moving there. You can see 5 layers. The lumen, which is always hyperechoic. Then you have a hypoechoic mucosa. You have submucosa, which is very difficult. Very rarely you can actually differentiate it well. Not as clear as in this picture. Then you have the mucolaris, the muscular part, which is hypoechoic, and then the serosa. This is how it looks like when I do it in the ICU. I can't get any better picture than this. I would love our radiologists to talk about whether they can get better picture than this. But these are very difficult structures to identify. The stomach is anyways quite difficult. It's the stomach which you are looking at. And all you can identify is the lumen, the serosa at times, and the submucosa at times. And when it is completely collapsed in the cross-sectional view, it is called as a bullseye view. This is not my video. I have not taken this video. I borrowed this video from my radiology department. Previous one was our video from the ICU. So this is a bullseye view which they call about. This is something which we can see sometimes. This is the peristalsis of the stomach. Easy to pick up. It's not very difficult when the peristalsis is happening at that place. It's not very difficult. The problem is that I often see these kind of images here. This is a dilated stomach with, you see some floaties in there which are quite sparkly. This is a real story of a real patient, a photograph which I put in. This is around 4 years or so ago. I got a call from my resident, a patient very, very sick. And there was this junior radiology resident in the ICU, in the radiology department, and there was this ICU registrar. Both of them called me up and said that there is a big collection just left subcostal area, and I think that's where the pus is. And we need to drain it, we need to put a needle and drain that out. So it didn't sound right. What is left subcostal spleen? I said, these guys are going to puncture the spleen. I better go to the ICU. So I contacted one of my other resident, the other consultant who stays close by. Unfortunately, he was not there. So it happened that I went in. And we drained this collection through nasogastric. So this is just a dilated stomach. It's not anything else. It's just a dilated stomach. So be aware that you should not try and overread it. When you're starting to learn in intensive care, when you're not a radiology trainee, when there is no radiologist watching you over your shoulder, you may start interpreting things in a different way and then create some blunders. So same like ultrasound of any other organ, this has got a learning curve as well. Comes down to the bowel ultrasound. Normal bowel diameter is around 25 millimeters for small and around 50 millimeters for large. The appearance is almost the same, 5 layers, and the liquid in it appears to move quite well. You can see them dilated. I've got a few good pictures of a patient who was recently with us. Luckily, after the linear talk, I saw a patient who who had intestinal obstruction, and I called my radiologist and said, take some good pictures for me. So I've not taken the pictures, but he's taken the pictures for us. But we have some good pictures to look at. So this is obviously not that. This is how you measure the diameter. So from any echo image, any ultrasound image, if you are going to measure the diameter of the lumen, it's always from leading edge to the leading edge. Whether it is heart, whether it is any other vessel, it's always leading edge to leading edge. So you take up the leading edge here, you go up to the leading edge at the bottom, and that's how the caliper should go. It's always leading edge to leading edge. So it's no different for stomach as well. This is a dilated large bowel. You can see the measurement was around 50 to 53 millimeters. Same each patient, different type of a view. Again, you can see the contents in there quite well. Again, some dilated look for the same patient. You can see the contents moving there. Not much happening out there. And this is a very interesting view. This is again not my video. This is a video which we have picked up from the internet actually. I could not get a patient to have a video like this. This is the reverse peristalsis, two-way peristalsis. You can see the fluid moving forward and then coming backwards again. So this is something which would be very, very significant of intestinal obstruction. So if you see this kind of a video with dilated bowel tubes, it's very, very significant for intestinal obstruction. You don't need to do a CT scan to diagnose it after that. This is something called the Tanga sign. Tanga sign is two bowel loops. This is a dilated one. This is lower loop below there, and you've got some free fluid there in between, which is called the Tanga sign. Again, this is not my video, but the idea is for us to understand. And I find it difficult. I mean, I was trying to look for this sign in the patient which I just talked about, and I could not make it. And after the radiologist went, I sort of an hour or two later, I sat with the ultrasound probe trying to see if I can actually got the Tanga sign, and I could not get that sign at all. Again, mesenteric ischemia, I think most radiologists have got a very good skill to look for mesenteric vessels, and they're able to give a reasonable explanation about what is happening with the velocities there. I struggle, we all struggle a lot. And I think it's a learning curve which we need to do. But again, as I said, that does not happen to be our core competency right now. It's just like echocardiography was not our core competency, so we were not learning with that often. But now, if you ask any intensivist, they are able to do a reasonable echo for by themselves. I think another 5 years' time, if I'm standing on the same podium, I might be talking a little bit differently than what I'm talking the way I am right now. The TRADAS waveform is not difficult. I mean, this is a waveform for velocity which is very, very high, and it is seen in any stenotic lesion, so it's not sort of specific for the mesenteric vessels. But any velocity which goes very high denotes stenosis, and you should always look for this abnormal type of a TRADAS waveform which you can see here, and that's quite significant that you've got a very high velocity across the portion which you are trying to measure. I'm not going to go into the complementary studies. Urinary bladder, we all can see the bladder, we all can measure the bladder fluid, how much amount of urine is retained in that, length into depth into height, multiplied by 0.56 or something, and that will give you an approximate measure. But remember, it's not a three-dimensional machine, so you would probably be off by a few ml here and there, 10, 20, 30 ml here and there, which is acceptable, but it gives you a good reason to sort of understand. Prostate, liver, spleen, gallbladder, again gallbladder wall thickness, gallbladder distension. I think that's something which we pick up, but I would again say that we pick up as a part of the sepsis protocol. We try and understand whether there is an obstruction of the gallbladder, whether there is dilation of the gallbladder, and then decide what to do about that. But we never go back and train ourselves to keep on following it up as to what is happening with that. There's something else which is renal resistive index, and I put this one slide because I've got one of my juniors actually. I think, if I'm correct, 2 or 3 years ago in the Reflects, in the Reflect, I had talked about renal resistive index. Was it? 2 or 3 years ago, I was talking about renal resistive index in one of your months. It was here or in Hyderabad, I don't remember. Following that, we actually got one of our DNB students doing a thesis on this, and it seems to be shaping up quite well in the ICU right now. We've got 2 or 3 parameters, including some hemodynamic parameters as well as kidney outcomes, and hopefully by April or so we should have the statistics in hand to come back and present this study to understand understand whether renal resistance index indeed is helpful for us, not only to predict the kidney outcome, but also to use it as a dynamic hemodynamic parameter to see whether it can actually give fluid challenge and improve in the sense zero point 0.5 to zero point 0.7 is normal. If it goes above 1, it is abnormal. So you need to bring it below 1 to see whether the renal resistance index indeed is improving or not. I think that protocol would be a way forward, as it has been with many other ultrasound protocols in the ICU. It is at the bedside, so there is no reason why we shouldn't be using it. It's non-invasive and can be repeated and can be reproduced as well. I would be happy to take questions. Thank you.
Sir, can I add a few points?
Please,
my experience on how to start a CUTS. So, as Sir pointed out, it's doing a bowel ultrasound is difficult among all of the abdomen. Looking at the solid vessel is much relatively easy, but when you want to look at the bowel or mentum or dysentery, it takes a bit of training. Even when we are training in our first year or second year, if we find any abnormality, we never move our probe. We just keep our probe in the same place till our senior or any of the faculty comes and check, because we are worried that once we leave that, we may not be able to find it again. So it requires a bit of a training, and you need to see a lot of normals. It's not like we can see the abnormal, we can identify the abnormal immediately without seeing any normal thing. And every time you may not be able to see with the linear ultrasound probe itself. Initially, you should start with the curvilinear, especially when you are trying to trace the lead point in case of obstruction or somewhere. Doing with the linear ultrasound probe will give you the resolution, but it does not give you the whole dimension of the abdomen force. So you have to start with your curvilinear abdominal probe, scan the entire abdomen, see where the bowel loops are dilated, and that area you can again switch over to a high resolution probe, and then you can scan where you are able to see the lead point of the point of obstruction. And as Sir pointed out, the blood flow, imaging the blood flow is like very important. And sometimes when you want to differentiate between ischemic bowel or gangrenous bowel or necrotic bowel, it is a very thin line of difference between all these things. Whether the bowel is ischemic or whether the bowel has gone completely gangrenous. Because ischemic you can still wait, you can continue your conservative manner. Once it turns gangrenous, you have to shift to the OT. So you can see on ultrasound, when the bowel is ischemic, all the walls layers which Sir has shown already, you'll not be able to appreciate the different layers. They all appear like one homogeneous.
Normal day they appear more.
So, and when it turns gangrenous, you'll find associated bowel dilatation also, because it completely goes off. Nobody can trace individual bowel loops blood flow. That is not possible. You can only trace the blood flow at the level of the superior descendant artery or senior artery, and a few first order branches arising from it. Anything distant to that, you will not be able to trace it. And TARDIS is a high resistance wave pattern. So basically, there are two wave patterns. One is a low resistance, where the blood goes very easily. Means, especially organs, postprandial bowel and kidneys, they are low resistance. You do not have a high resistance blood flow. The blood should go easily for you. So they are at a low resistance. When it turns high resistance in that period, it means the blood is somehow not able to conduct smoothly. There is some level of obstruction in those areas. So as a whole, it's not something which is impossible or difficult. Everybody can do that. Only thing is, you have to start seeing it more regularly. And because now for children, even we do not prefer CT. Everybody wants to diagnose everything with ultrasound only, especially, and that is the correct way to go ahead. At least in adolescents and young children, we must be able to diagnose all these things with ultrasound only. So with the bedside modality, with ultrasound only, we should be able to differentiate, because the entire trend of abdominal injuries or solid visceral injuries in management of children has turned over to a conservative pattern rather than going towards an aggressive, invasive way.
is that it has got a very steep and a long learning curve. It's not like cardiac ultrasound, which has got a steep learning curve, but it's not very long. You see a few, and because you start to see what is normal very easily, and the windows are so easy to get as compared to the abdominal windows. I think that the learning curve is not very long. Here it is a steep as well as a long learning curve. This is where the motivation factor comes into the picture.
Gastroenterologists have started EUS, endoscopic ultrasound. So they are able to combine their ultrasound with that. So when you are very focused on the bowel, and entire thing is very difficult and challenging things. You have to see a lot of cases, means lot of abnormal cases, and you want like mesenteric, momental, lymph nodal pathologies. All these things are very difficult. But when you are very much focused, yeah, I want to see the bowel loops, means because even for intestinal obstruction or paralytic just to differentiate them. Even with institute, we want the same person to be looking at it every day. We know if I see and tomorrow somebody else sees, they will not be able to differentiate because the bowel loop's position changes, the way the peristalsis happen changes. So you want the same person to keep looking at it. So that is how subjective it is. Whereas CT, somebody, another work, it can be done somewhere else and you can bring it here and you can read it. But that is not how it is. You have to do live and you have to see it for yourself to understand. So even when you are doing a follow-up, the same person should be available the next day to see it. Because somebody else comes and tries to follow up that case, it's not going to be easy for them because they don't understand how it was yesterday. In spite of how well images you have taken or a detailed report you have written also, it is not going to be easy to understand, to have a pictorial representation of the scene. You have to see it only for yourself to believe what is happening.
Already cardiologists are complaining that intensives have taken the echo away. Now I think radiologists will complain in 2-3 years time that the ultrasound of the abdomen is gone. I can hear some music, maybe Mohan Maharaj is planning the party already. Thank you guys.
With guts protocol, whenever we put a right tube, as a gastric tube, we do a chest X-ray. So I think
you can avoid that.
Can we avoid that? And also, suppose they are not able to tolerate the feeding, we can even, is it possible to push to jejunal also?
You can observe it, whether it goes or not, we don't know.
Are you observing all these things right?
I am not observing.
Please, and
this requires a lot of perseverance at the bedside. Okay, so we are not doing it, but that doesn't mean that it cannot be. It's actually very easy to observe a right tube. It's not very difficult to observe. The stomach is very easy to ultrasound. You can easily see the right tube inside.
And sometimes what happens when a patient is more sick and patient is on ventilator, vasopressors going up and source is not able to identify. Sometimes what happens, admits with some reason and their vasopressors are going up and bowel ischemias, whether occlusions or submucosal changes, is it possible to identify such type of patient? Because they won't complain of a pain abdomen,
yes,
but lactates are going up and acidosis is increasing.
So you need to have a deep clinical suspicion that there is something going wrong in the abdomen, and then you look at these abdominal findings. And yes, you can identify them, but as I said, it requires a lot of learning. It's not very easy to diagnose ischemia and ask the surgeon to go and operate. I would probably do it more on a clinical hunch than anything else.
Because most of the times when we ask radiology, they ask to do a CT scan. So
that's why we got a radiologist here.
right.
I agree. Most of them would not comment on ultrasound. See, it's like putting your foot down and saying that unless you're very, very sure, and that surety is very difficult to get. I must have, after you guys gave me this topic, I must have done ultrasound for so many. Every day I was doing it for 10, 20, 30 minutes, trying to understand. I'm telling you, even now, if you give me an ultrasound and a patient, the 5 layers of mucosa the intestine cannot identify them correctly. Yes, sir.
Right, like the right position. It's a thought process. Maybe it's right or wrong. Pushing air and seeing some curving, like what we do it in ASD.
Air will, if there is some fluid in there, it will give you some swirling motion there. But otherwise,
identifying the ASD, they do 2D
air bubble.
saturated
saline.
I understand, agitated saline, I understood
The
what you're
same
saying.
thing can be extrapolated to here also.
So legally, if the patient is having patient is having a mesenteric ischemia and the patient is unstable, so we can't shift for a CTI. Can we diagnose it on GERD protocol and then can we take it to the operating room? Legally, I would right.
Yeah, you are right, absolutely legal. Forget about ultrasound, that is the clinical diagnosis. So, gut ischemia many times is a clinical diagnosis. Even on a CT scan, and the radiologist will corroborate that, you are not able to pick it up every time. So, you will need to sometimes go in and have a look. Sometimes the surgeons will go in and if the patient allows, they might do a diagnostic laparoscopy before they open up. It all depends on hemodynamics of the patient. If the patient is extremely hemodynamically unstable, they are not going to put a pneumoperitoneum to do a laparoscopy. They might just have a quick laparotomy and have a look. So you are absolutely fine to legally support your diagnosis on ultrasound if you can. Otherwise, you can go it on